talk a little bit about imaging, but mostly I want to talk about some of the things we're thinking about recently in Alzheimer's disease. I've just picked out a couple topics that are current and which I thought might be of interest to you, and I'll keep it light and be interested to take your questions. And can everybody hear me okay?
Yes.
No microphone involved. So we're going to talk about biomarkers because there's been a lot of advances in Alzheimer's disease biomarkers that are going to make it possible to study this much more effectively. We'll talk about recent exciting work that's been underlying the frequency with which network hyperexcitability and subclinical epileptiform activity may play a role in Alzheimer's pathogenesis. And then we'll talk about resistance and resilience to Alzheimer's disease at the end. So this figure is something I see about 30 times a year in any presentation that's made around Alzheimer's disease biomarkers, and I'll unpack it a little bit. What you see going across the horizontal axis is advancing Alzheimer's disease through a latent pre-symptomatic stage through dementia, and the green shaded area here is the range of disease course over which the cognitive symptoms become apparent. But what is equally apparent is there's a long phase before there are any symptoms, before there's even mild cognitive impairment, during which there are markers of Alzheimer's disease process that can be detected. And these are spinal fluid and imaging biomarkers that we'll talk about in a minute, but make it clear that the disease is going on maybe 15 years in advance of any symptoms. And that's a super important fact. For every person you know with symptomatic Alzheimer's disease, there are 2 people in the pre-symptomatic phase. And all these numbers you hear about the gray tsunami multiplied by 3 is the number of people that are actually affected by this. We are moving to a place where we're really radically separating the concept of Alzheimer's disease as a microscopically defined pathological process from dementia, Alzheimer's dementia, as a clinically defined cognitive process. And the new National Institute on Aging and Alzheimer's Association research framework for diagnosis, research framework for a diagnosis of Alzheimer's disease is radically biologically based. Okay. And so to introduce that, let me just point out that it's 2019 and our understanding of Alzheimer's disease is still pretty descriptive. Alzheimer's disease is defined by really the presence of 2 microscopic findings, amyloid plaques with a neuritic surround, it's called neuritic plaque, and intracellular neurofibrillary tangles composed of hyperphosphorylated tau protein, 2 markers that pretty much define Alzheimer's disease present. They're markers. We don't really know what role they play in the pathological processes, the pathways that cause Alzheimer's disease to unfold the way it does. But we're now able to detect these markers, if you will, with imaging and spinal fluid tests. And this is the basis for this system that is being called the ATN framework. So ATN stands for A is for amyloid, T is for tau, and that's the marker of the plaque and the tangle respectively, and N for neurodegeneration, which is a nonspecific tissue impact marker. We have several ways we can measure amyloid in the brain, either with spinal fluid protein assays or amyloid PET scans, and I'll show you a couple of those. We have likewise, parallel to that, a couple ways to measure tau markers in the brain through measuring the pathological species, phosphorylated tau in the spinal fluid, or the most recent development, tau PET scans coming to a university near you, and then several ways that are several diverse ways actually to measure and estimate neural degeneration. But in this framework, one important thing is that everybody, every participant can be classified in terms of where they fit on these three biomarker axes. So for example, on the left, this is someone who has a positive amyloid PET scan, has a positive tau PET scan showing a tracer taking up in the temporal lobes and the parietal lobes, and a structural MR scan which is showing hippocampal atrophy and cortical atrophy. So A positive, T positive, N positive, and that would be a full-blown Alzheimer dementia case. And on the right, someone who has a positive amyloid scan, a negative tau scan, and a normal structural MR scan. So A positive, T negative, N negative. This would be pre-symptomatic Alzheimer's case. Someone way on the left of that canonical biomarker curve I showed you at the beginning. And in this framework, then we can, there's basically 8 possibilities. And in the framework, if you are someone who's got a positive amyloid marker, A plus, we say that you have Alzheimer's disease pathological change, or if you also have a positive tau marker, Alzheimer's disease full stop, regardless of what your cognitive state is. So for research purposes, Alzheimer's disease can be diagnosed with a positive amyloid and a tau marker, regardless of the cognitive status of the patient. So I would say it's radically separating the idea of the biology and the consequences of the disease. And if you don't have a positive amyloid marker, even if you have a positive tau marker, you don't have Alzheimer's disease. You have some other non-Alzheimer's degenerative condition. Does that all make sense? And then if you ask, well, what do you do with a cognitive? We'll use terminology like this. So here's A positive, T negative, N negative. So we say preclinical Alzheimer's pathologic change. But we say there's an Alzheimer process present. If you have mild cognitive impairment, it's Alzheimer's pathologic change with mild cognitive impairment, or Alzheimer's pathologic change with dementia. So very descriptive. So this is something that's been kind of rolled out over the last 2 or 3 years through the Alzheimer's Centers program, and was just published. There's been a significant amount of pushback with this framework. One reason for the pushback would be issues around the semantics of the term disease. Okay, I don't know if any of you feel the same way, one, it's a fact that many people who are shown to be have amyloid and tau pathology at autopsy were not demented or even necessarily cognitively impaired in life. We want to say they have Alzheimer's disease in life if they have like the proper biomarker studies. Should asymptomatic people be diagnosed as having a disease? That's a semantic question. And then there's issues around the stigma attached to the term Alzheimer's disease. And if we're using this in a research framework, I'm saying it's not ready for clinical terms, are we really going to be able to keep a wall between the research realm and the clinical realm? And in the information age, I'd say probably not. So there's going to be lots of, I think, pushback about using the term disease in an asymptomatic individual. But on the other hand, I would submit this is really a lot of progress because we're now defining specific biological states that we can now bucket patients for interventions, and we now have a principled way to analyze preclinical Alzheimer's disease. There's no way to do that with just clinical data. And finally, we can now have some quantitative handle on how to bring resistance and resilience to Alzheimer's disease into focus, and I'll talk about what I mean by that.
It seems that, dementia, to a simple neurosurgeon, I guess, dementia is being demented. And you've now defined a disease that can exist as a dementia without dementia. Are you defining a biological phenomenon that's unrelated to clinical dementia? It looks like these are diverging rather than converging.
So that's a good question. So dementia is the typical manifestation of Alzheimer's disease, but there are milder milder forms. So before people have dementia, there's a phase of so-called mild cognitive impairment where one can objectively measure episodic memory impairment, but daily living is fine. Many of my patients with mild cognitive impairment are still working, are fine in daily living. So you don't want to call them demented. Go even earlier, and you get to a stage where you might measure very subtle problems with cognition or no problems at all. So I'm just saying it's all on a continuum. You can make an analogy to renal disease, right? You can have renal insufficiency but have really good functioning overall. You can have preclinical aspects of other diseases. It's just that we're defining the disease in biological terms. All right, so how many people have seen the amyloid PET scans? Michael, I have a few people.
When are they coming here?
So amyloid scans have been available now for about 10 years. 2 or 3 years ago, Medicare decided to pay for a certain number, I think about scans nationally as part of an evidence development program called the IDEA study. So these are scans that were done under the IDEA study for which we were a site. And we're done for to support clinical decision making. Right now, we can't do them for clinical work until CMS decides whether they're going to cover these going forward. So what you see on the left are 2 negative amyloid scans, and what you see on the right are 2 positive amyloid scans. And the way to tell the difference is if you can see the gray-white matter distinction, as you can in the 2 left-hand cases, that's a negative scan because the tracer gets taken up non-specifically into white matter, into the myelin. On the right, as you can see, there's you lose this nice skeleton of white matter. It's all kind of a ground glass appearance on the cortical rim. So those are clearly positive amyloid PET scans. And the interesting thing is it's hardly ever a close call. By the time people present with mild cognitive impairment, the amyloid scan is floridly positive. And usually, in a sense, maximally so. And the pattern of amyloid deposition doesn't seem to respect any clinical variability in the case. So if someone presents with an amnesia versus an aphasia, for example, the amyloid scan will look the same.
In that study, were there any people with clinical dementia and not positive amyloid?
Right, so there are people that are in that bucket. The descriptive term that's been used is SNAP, SNAP, suspected non-Alzheimer pathology. One of the big reasons for SNAP turns out to be we're now understanding that a substantial number of people have a deposition of TDP-43 protein, which is a newly described amnesic cognitive impairment and dementia causing syndrome that's got the acronym LATE. Limbic predominant TDP-43 disease. So yes, there's a differential diagnosis for amnesic dementia. I mentioned the IDEAS trial. So the interesting thing about this trial was that the availability of that amyloid scan actually changed diagnosis or management in 65% of the cases, mostly medication management. So it looks like it has a huge clinical impact. Now I'm showing what a tau PET scan looks like. Tau PET behaves very differently than amyloid PET. Tau PET makes a really close partner for the clinical phenomenology. So if you have someone presenting with an amnestic syndrome, you'll see a concentration of phospho-tau in the medial temporal lobes. And if someone has a more cognitive impairment, you'll see a much more widespread tau tracer uptake, and the atypical cases are tracked closely by atypical distributions of tau. This is what a typical tau PET scan will look like using a tracer called MK6240, which is the one we'll be using here. That's a tracer that's marketed by group called Serbu Technologies, and I've been telling everybody this is coming next month for about 6 months now, but it'll be ready this month. So to summarize, these brain imaging markers, the amyloid scans are detecting amyloid plaques. You have to have moderately dense plaques to show a positive scan. In the stereotypical distribution, leading symptoms by about 15 years. And the use that this is being put to is to certify diagnosis, especially for clinical trials. And there's an alternative test, which is spinal fluid measurement, because you don't really get any spatial information from this test. You might as well also use spinal fluid. And then the tau scan, which detects the distribution of tau tangles, and not just the tangles, but all of the neurofibular pathology, so the neuritic surround of the plaques and the neuropil threads and so forth. Has a more variable distribution that correlates well with symptoms and can be used to track the advance of the disease. It really looks like the tau scans show measurable differences from year to year, and may be a good surrogate marker for a good progression biomarker. And here's just to make the point that the tau scans track the impact pretty well. So top tier is typical amnestically presenting Alzheimer's disease with a Braak stage 3 or 4. You can see a nice correspondence between the kind of average tangle distribution in Braak 3 and 4 to what we see with the tau scan, and in 3 dimensions over here. And on the bottom tier, we have a more unusual case of a patient presenting with visual symptoms, the so-called posterior cortical atrophy variant of Alzheimer's disease. We have maybe 20 cases of this in our registry of 500 cases that present to an ophthalmologist because they have higher visual impairment, something resembling Bellin syndrome. And the atrophy is predominantly posterior with relatively spared hippocampus, and you can see the tau tracer also distributes posteriorly. So nice, looks like a nice tool for the future. Okay, so that's the canonical biomarker suite that we have right now. One really exciting development in the last couple of years of what's looking like was plasma amyloid beta test available. So right now we have to take spinal fluid to measure this. This is the slides I'm going to show come from Washington University in St. Louis, and the leader there is Randy Bateman. Just as an overview, to remind people that amyloid is proteolized into fragments. There's a fragment from 1 to 42, which is the chief component of the amyloid plaque. There's a 1 to 40 fragment, which doesn't accumulate in plaques. So what happens is, as time goes on, amyloid beta 1 to 42 doesn't clear from the tissue. It hangs up in the tissue. The level of AB42 falls in the spinal fluid in consequence. And the ratio of 42 to 40 also falls in the spinal fluid. That ratio turns out to be the more sensitive index of disease process. We know that a lot of plasma A data originates in the spinal fluid, but we've been unable up until recently, until the use of new mass spec techniques, to be able to sensitively measure this and show group differences between Alzheimer patients and controls. But now we're able to do that. And this is just data from Bateman's paper. This is just a pulse chase kind of experiment where they label leucine with a detectable isotope and show that over the next few hours there's a differential in the between amyloid beta 42 and 40 in the plasma. This turns out to be about 15% lower in the Alzheimer cases than in the control cases. And this graph shows control participants in blue, Alzheimer patients in red, plasma AB42-40 ratio on the y-axis, And in this box, it's just showing the correlation of the spinal fluid and plasma measurements, which is highly significant. And in the right panel, showing this is amyloid PET now on the x-axis, and these are the Alzheimer cases all showing high amyloid PET measures, and the control cases show low. You can see that the plasma A-beta is identifying all of the Alzheimer cases, but also some of the control cases. So it's looking like the plasma marker that's available now will be will have a good predictive value negative, and we'll have a screening goal, but won't substitute for these other biomarkers, at least not yet. But it's got a good ROC curve with that area under the curve of 0.89, so it's looking quite promising. And these results have been replicated by an Australian group and a Spanish biotech company as well. So we're going to see plasma markers coming on the research scene in the next 2 or 3 years. I think I said all this. Questions about that? This will be a game changer. We work in all sorts of situations where the spinal fluid measurements are not so acceptable to people.
Do we have
the clinic, for example, but also research institutes.
Do we have any theories where that, blood-brain barrier should happen, it shouldn't leak out in there? What's the theory of why that tracks with what's happening with the brain?
Well, I think the amyloid's in the spinal fluid, and there's no barrier between the spinal fluid and the yeah, so the blood-brain barrier problem is extremely bad. We are looking at another radio tracer which is coming on the scene now. So this is a new radio tracer that measures synaptic density. The tracer was developed at Yale by Rich Carson's group and is looking at synaptic vesicle glycoprotein 2A, so SV2A tracer. This is a protein which is a ubiquitous component of all synapses in the brain, sort of like synaptophysin. And there's a carbon-11 compound that has a beautiful affinity for this protein. Rich Carson says the best behaved radio tracer he's ever seen. That's available, or it's really got a very stable measurement that's amenable to parametric imaging without smoothing the data, so it's a nice PET, high resolution image of synaptic loss, which we think is maybe a really nice phenomenon in neurodegeneration. So this also looks like a really interesting picture. Interestingly, it shares the binding site with acetylmethyltransferase. So this was published in Science Translational Medicine last year. And to show you the validation data, I thought I'd just introduce it this way. Alzheimer's disease doesn't affect the brain evenly, as I've been trying to point out so far. Tangles show up more densely in the temporal lobe and in the inferior temporal cortex than the other aspects of the neocortex, and relatively spare the primary regions. Where tangles like to show up first is in layer 2 and layer 4 of the spinal cortex. And the consequence of those tangles appearing in the entorhinal cortex is that the perforant pathway that projects from entorhinal to the dentate gyrus or the hippocampus is sort of surgically struck, right, is disconnected from the posterior cortical systems. And you would expect that the correlate of tangles here, if those are marking the degenerating systems, because you'll have synaptic loss in dentate gyrus. So early synaptic loss in dentate gyrus. And so that's the validation that Rich Carson put this tracer to. And what you see, these are just some of the descriptive pictures in the paper. But this is a normal SV2A scan, and the rest of the scans show reductions in hippocampus of varying degrees along the severity of Alzheimer's disease So this tracer looks promising. It's well correlated with episodic memory score and global cognitive measures. So we're thinking that this shows in early cases where the reductions are happening, not just in medial temporal lobe, but in some of the connected regions. And this is consistent with what we know clinically, that the involvement of the temporal lobe, the severity of involvement seems to vary with the connectional distance to the neuronal cortex. So it's a promising tracer of synaptic density. We're thinking it may be an exquisite neurodegeneration marker and a good progression biomarker. We're waiting for a fluorinated version of this tracer, something that will have a longer half-life and be easier to work with.
Tom, is this specific for AD, or could this be used with any disorder?
Any disorder.
Any disorder.
Any disorder. So you could use this in Parkinson's disease. You could use this in multiple sclerosis. As a non-specific, as a sensitive neurodegeneration marker from any process. So this, under the ATN framework, this is N. This is what's coming for N. Okay. Now I'm going to shift gears and talk a little bit about network hyperexcitability and subclinical epilepsy and Alzheimer's disease. Have other people heard of this finding? This is new to the audience mostly. So the sort of proponent of this is this neuroscientist Leonard Mookie at the Gladstone Institute at UC San Francisco. And his clinical disciple, Keith Bossel, a neurologist who's now at the University of Minnesota. By way of introduction, episodic memory depends a lot on the medial temporal lobe, on the hippocampus, but it's really just a critical node in a whole system that's operating that includes not just the hippocampus and the neuronal cortex, but also the default mode network and the lateral front parietal attentional networks. And there's this dynamic interplay where the hippocampus is active during a situation of perceived novelty, and the default mode network is suppressed during this encoding operation, and then during retrieval, the default mode network will become active to support the retrieval process. So there's this system interplay that's happening. So the signature is activation of the hippocampus and the activation of the default mode network. And what we have found with imaging over the years is that in the mildly symptomatic Alzheimer's state, that is the state of amnestic mild cognitive impairment, the hippocampus activates too much, more than it controls to do. So you see that here, control MCI, and then when you get this either late MCI or something that you would call Alzheimer's dementia, the activation is less and actually in the end goes away. So there's this transitory phase of hyperactivation of the hippocampus. Shown again here in rhesus Sperling's work. This is about 10 years old now, maybe 15 years old. But there's, in early MCI, a lot of activation, in the late MCI, not much activation. So what is going on there? This has been interpreted as a compensatory phenomenon, but most recent data suggests it's actually pathological. Just almost a response to illness kind of curve here. Early on, there's a counterproductive hyper excitability of the hippocampus and the sort of burning out as time goes on. This was a really nice study where they were doing fMRI work with amnestic mild cognitively impaired patients, and they showed hyperactivation of the hippocampus in a specific memory task. They were able to eliminate this hyperactivation with low-dose levetiracetam, and supporting the idea that the hyperactivation is pathological. In the mice that Leonard Mookie has studied, what happens is These are transgenic Alzheimer's mice, and they're showing network hypersynchrony, especially during sleep, and they're showing lots of subclinical epileptiform activity, especially during sleep. And you can see that the spikes here in the resting period, vanishing in the active period, and again, appearing in the resting period with similar hypersynchrony findings in some human patients. And Keith Fossel followed up on these findings in the mice with a human study. He was still at UC San Francisco, and they had, I think, 60 mild Alzheimer cases and 60 controls. And what they did was to get prolonged video EEG recordings and then a magnetoencephalography recording the next day. So they did more extensive recording than you would typically do in the EEG lab. And they found epileptiform activity in 11% of the controls and 42% of the Alzheimer patients. And maybe more importantly, those who had epileptiform activity over the next 4 or 5 years showed a much steeper decline in those that did, suggesting that there's some relationship between this hard to detect epileptiform activity and prognosis in Alzheimer's disease. So the current thinking is that there's something about the amyloid protein, something about the interaction of the amyloid protein with the neural systems that's leading to irritability or hyperexcitability of the membranes and propensity for these subclinical epileptiform events.
Those bottom graphs are too pretty and too straight. Do you know how many time points they actually represent? I've never seen perfect lines like that in a study.
I'm sure that they're just graphically displaying the results of a model. I don't think this is. This is explaining the data that occur. That's a good question. I'll send you. And then this paper from Andy Cole's group at Mass General got a lot of play as well. There were 2 patients that were presenting with dementia and some prominent fluctuations in their status from day to day, but no overt epilepsy. And they put per M in the Valley electrodes and found a lot of epileptiform activity and subclinical seizures during sleep. And one of the patients resolved completely with levetiracetam. So, and I didn't mention that in the epileptic mice, that's what the Alzheimer's mice, that show the epileptiform activity. Low-dose levetiracetam works perfectly in suppressing those abnormal discharges. So there's this strong hint that we're missing a component of the pathophysiology of the disease in a lot of our patients, and it's something that's potentially treatable with anticonvulsants that we have available to us. So this work was presented, there was a symposium at the American Epilepsy Society year before last on this topic, which really brought this into the scientific sort of public eye, and so we hear a lot more about this going forward. It really does make me wonder whether we should be more aggressive in looking for this phenomenon in patients. For those of us who take care of patients with Alzheimer's disease, we hear all the time about good days, bad days, sometimes really bad days, where it takes people a day or 2 to recover. You wonder whether there are some events that we're missing. So network hyperexcitability occurs in the temporal lobe, perhaps more widely, perhaps more commonly than we previously realized. Yeah.
Is this a primary hyperexcitability, or is it a lack of inhibitory input to those cells? Do we know?
We don't know.
We don't know yet.
We don't know. This is sort of still in the sort of gee whiz phase, right? It's a phenomenon we're trying to get people to believe.
How does that surprise you, though? If your model of epilepsy is that it's sick neurons. It's a response of sick neurons. That's what you sort of expect. You have this phase when the neurons are sick and they're hyperactive, and when the neurons finally die, then you lose the marker.
So generically, you mean in any
Yeah.
disease process?
Yeah.
Why not? Why not? But why wouldn't it still be clinically really important?
Oh, I think it is
Yeah,
important.
hugely.
I'm not
Yeah.
arguing that.
Yeah.
I just think that it's almost what you'd expect with sick nerve cells losing their synaptic inputs. I mean, that's been the model of epilepsy, at least around this institution, for a long time.
I think it's a great point.
As the neurons get sicker and die, one, George and I anyway, would expect the epilepsy to get better. Does that happen?
We don't know. Your question presupposes that people now agree that epilepsy is happening. Yeah.
So the case report of the patient being treated with Keppra, did it result in clinical improvement of the patient?
Sorry,
The reason I'm asking that question is it's kind of a follow-up of Dr. Ocean, is that sure, there could be hyperexcitability locally or network-wide. That doesn't necessarily mean they have epilepsy.
Right.
It's not quite the same.
Right.
You know,
It's true.
there are lots of, you can pick up on epileptiform discharges that are focal that don't result in epilepsy, at least in a clinical phenotype.
Right, so your question is, does intervention help?
Yeah.
Anecdotally, yes, but Keith also has a clinical trial going that maybe we'll get an answer to that. So there's Keith's trial and there's another phase 3 trial out there addressing that question. Okay, and right now we think if we really want to be sensitive to these, we need to do an EEG during sleep. Okay, and then finally I want to talk a little bit about the phenomena of resistance and resilience to Alzheimer's disease. To review, Alzheimer's disease pathologically shows a fairly stereotypical advance of neurofibrillary pathology in certain regions of the brain that correspond to pre-symptomatic mild cognitively impaired and dementia phases of the disease, altogether 20, 30, 35 years of disease. But the relationship of Brock stage to clinical stage is actually malleable, and the actual relationship looks more like this, where it's possible to have more severe pathology but be in a state where there's a milder clinical phenomenon. So some people with Brock 4 have mild cognitive impairment and some will have dementia. Some people with Brock 2 will have no symptoms, but some will have mild cognitive impairment. And the factors that govern that have to do with, I'm missing one of my, so comorbidity sort of drags you back. That seems pretty obvious, concurrent cerebrovascular disease, for example. But what you do over your lifespan in terms of cognitive engagement, aerobic cardiovascular fitness, social connectedness makes a difference and helps you lean into the disease, actually. So those factors can make a decade of difference in terms of where your personal tipping point will be. And so that's, back up because I got them out of order. So that's the phenomenon we're calling resilience, which is you might be in a situation where you have mild or no cognitive impairment despite a pathology load. Okay, so there's varying degrees of such resilience. The strongest, well, the easiest, strongest predictor of this is your degree of education. But it also has to do with things like how challenging your job has been, what your cognitive habits are like. Do you spend 3 hours or more a week in cognitively demanding activity or not. Most of us at the table here are no problem on this, but doesn't necessarily represent the human race. And then there's this other aspect of other sense of resilience, which is a more biological. I'm calling it biological, which is that despite a high risk for Alzheimer's disease, the pathology doesn't develop in the first place. You think of someone who might be APOE4 homozygous that doesn't develop plaques and tangles, for example, or someone whose father has a genetic mutation for Alzheimer's disease, but the child who carries the mutation doesn't develop. That would be a resistance. Two different things. And we're very interested in these phenomena because sort of equally likely to give you clues for therapeutics as studying the disease pathways in the first place. Okay, so here's just as an example, these are data that come from our Memory and Brain Wellness Clinic itself, just to illustrate this phenomenon of resilience. Look at the top graph here. What we're looking at is we've taken the three-dimensional T1 weighted scans done for clinical purposes. We've regressed the brain volume corrected for total intracranial volume on their Montreal Cognitive Assessment Score, adjusting for age, and we're looking at the residual in that regression. We're basically showing that how someone on average is doing for a given amount of brain atrophy on the MoCA test, as a function of years of education. And you can see that for those people who have high education, they have 3 or 4 point advantage on the MoCA score for the same amount of brain atrophy. They tolerate brain atrophy with better cognition than patients with lower education. And you can show the same relationship if you look at activities of daily living. There's more functional impact of a given amount of atrophy for someone who has a lower degree of education and a higher degree of education. That's the kind of phenomenon we're looking at. And you can use the biomarkers that I talked about earlier in the hour to demonstrate this as well. And this, I think, was one of the better studies. So what we're looking at is higher versus lower educated Alzheimer patients who have the same degree of dementia versus people without dementia, and the parameter that's being mapped is the tau PET scan. So you're showing that both the higher and the lower educated groups are showing accumulated tau relative to the control group. If you compare the higher to the lower educated group, so 17 years of education on average versus 12, there's a lot more tau burden in the higher educated group. And the reason for that is it takes more tau pathology to drag down the higher educated person to the same level of performance. And if you look at how this kind of works in terms of kind of a pseudo Brock staging done not with pathology but with the tau PET scan, you can see that it's high Brock stage cases are all in the high educated group. Okay, so for a given amount of dementia, a low educated person may have a low Brock stage, and a higher education person probably has a higher Brock stage. It takes more tau pathology to drag down a higher educated person. So this is, as I mentioned earlier, one of the advantages of thinking of Alzheimer's disease in this ATN framework. We now have a handle on how to study resilience with biomarkers. Okay. And I thought I'd close with a finding that my colleagues Caitlin Latimer and Dirk Keene reported just this year. So we're looking at now in the ACT study cases that are resilient or resistant to Alzheimer's disease. So these are people that were in a longitudinal study of dementia risk, population-based study of dementia risk. We then had an autopsy at the end to find out what the truth is. And we found that those who were resistant to Alzheimer's disease, that is, they were very elderly but had minimal Alzheimer's pathology, versus those that had the same amount of pathology but actually had dementia, the big difference was the comorbidity, and especially this protein deposition using TDP-43 protein that I mentioned a little while ago. It looks like TDP-43 is a super important part of the equation. We don't understand why some people with Alzheimer's disease accumulate TDP-43 and others don't. And Caitlin followed this study up with a really beautiful study in Seattle where they put both tau and TDP-43 mutant genes into the worm and found this amazing synergistic pernicious effect and almost none of the what's the right term, doubly affected, doubly hit worms survived. So it looks like there's some pathological interaction in some patients between TDP-43 and tau. So that's going to lead her into some really interesting studies about Alzheimer's disease resistance and resilience. So resilience really is a key dimension of the clinical presentation, and we don't really right now have a great way of determining on an individual patient's basis what their resilience measure marker, let's say, the resilience marker would be. That's something I think is sorely needed. It does affect how you interpret imaging. You see all the time people with quite a bit of cortical atrophy and no symptoms. That could be because they're a resilient individual, but there is actually a disease process going on. And my sense of it is that their pre-existing resilience factor has got to be important in terms of how well you respond to treatment. So I think this is something that we'll see a lot of attention to in the field in the next few years. Okay, so that's